next topic is by Dr. Sujatha. She'll be speaking on post-op refractive surprises.
A very good morning to all of you. So today I will be talking about post-operative refractive surprises following cataract surgery. So I would be discussing this topic under 4 headings: etiology, prevention, diagnosis, and management. So normally, what is post-refractive surprise? It's nothing but failure to achieve the intended post-operative refractive target in a patient. So when we study the cataract surgery outcomes, so in 50 to 70% of patients, we notice that normally we can achieve a refraction of 0.5 diopters, and in 70 to 94% it's 1 diopter. Factors influencing this refractive outcome can be divided into preoperative, intraoperative, and postoperative. So preoperative causes, we should never ever miss looking into the patient's files. It could be just a wrong lens that has been implanted in a patient, or it could be just wrong IOL selection, inaccurate biometry, or it's right-left confusion, or sometimes even an optimal IOL power not available in the stock. So generally, it's because of inaccurate biometry or IOL power miscalculation that results in this post-refractive surprises. So coming to biometry, pitfalls in axial length measurement, it would occur because for every 0.3 millimeters of error in axial length measurement, 1 diopter refractive error can occur. And these could be the sources of error like globe irregularities, intraocular material, poor ocular fixation as a nystagmus, or any oculomotor dysfunction, and human errors as well. And these errors in axial length measurement are higher in eyes with longer eyes and then shorter eyes, and in patients with macular staphloma and silicone-filled eyes. And keratometric errors, it's generally 1:1 ratio. An error of 1 diopter leads to an error of one diopter error of keratometry can result in 1 diopter postoperative refractive surprise. And these could be the sources of keratometric errors. And we should always exclude dry eye disease, epithelial basement membrane disease, and Salzmann's nodular degeneration, and even pterigiomes whenever we are doing keratometry. And we should avoid using any drops prior to doing keratometry. So these are just a glance through the normal physiological values. And these are the formulas available in our armamentarium. So these are the different generation formulas. Now we are going ahead with actually 4th generation formulas, Barrett's and Olson's, and then Holiday 2. And yes, we should always be very, very particular about the formula we choose while doing IOL calculation. So these are the different, this is a norm that we generally use. And nowadays it's Barrett's, and Barrett's, which is really, really useful to us, Barrett's Universal 2. So that addresses all axial length. And we can get predictive results in all the axial length patients, with all the axial lengths. And these are the vergence-based formulas, and which Barrett's Universal 2 comes under vergence-based formulas. And now we have Hill RBS and RBF and our ray tracing formulas like Olson also available in our armamentarium. And future trends, so now Barrett's Universal 2 is very promising, and something like Lada's super formula has also come up, and Olson's is also very promising, which uses ray tracing technology. And newer instruments available for biometry like IOL Master 700 and LensStar. IOL Master 700 has addressed many problems like able to calculate the axial length in dense cataracts and also patients with poor fixation. And we should never ever forget to calculate the effective lens position, which is very, very important. And in Barrett's Universal 2, we have all these predictors of ELP, because this determines the post-operative refraction. And next, coming to the other special situations like history, we should never ever forget to go for history of refractive surgery and keratoconus. And the calculation of IOL power following refractive surgery is a completely different topic, but again, clinical history method would definitely yield good results. And coming to intraoperative causes, so it could be just a decentration of rexus by 0.4 millimeters, which can result in a refractive surprise, or incomplete overlap of the IOL, or decentration of even a monofocal aspheric IOL also causes post-operative refractive surprises. So uneven full cataract surgery is integral to maintain effective lens position and the target refraction. And we should also be very careful about the surgical induced astigmatisms, and we should always calculate our own our own A constants. We should personalize our own A constants to optimize the refractive outcomes. So during surgery, even if the placement of IOL changes from capsular bag to coeles sulcus, this is a norm that can be used to titrate our IOL power. And coming to the post-operative causes, shift of IOL or IOL tilt or even late causes like capsular block syndrome or anterior capsular contraction syndrome can also result in refractive surprises. So then how do we prevent it? So reconfirmation of keratometry is required in all these situations, and even reconfirmation of axial length is required whenever there is discrepancy of about 0.7 millimeters between both the eyes, and measurements that even don't correlate with the patient's refractive error. And we should never forget to optimize our A constant. And these are some of the online resources for A constant optimization. So this is very helpful. And now, how do we diagnose the cause? So we should always wait for 1 month till the refractive error gets stabilized after surgery, till the refraction gets stabilized after surgery. So we need to go for a complete cycloplegic refraction. We have to recheck the patient's history. We have to we have to reevaluate the surgical records of the patient, and we have to see which IOL we have implanted. So we have to repeat everything. And if no source of error is evident, then we have to presume that it is because of effective lens, improper effective lens position. So how do we manage it? It could be conservative, so by spectacles or contact lenses. Contact lenses can be used in patients with anisometropia or high astigmatism. Or we have to titrate whether it's cylindrical error or a spherical error. If spherical error, myopic error is generally well tolerated. And multifocal IOLs, they are less tolerant. EDOFs are well tolerant again. And hyperopic surprises is very difficult to handle. And cylindrical errors, minimal cylindrical error, it enhances depth of focus. We don't need to worry much. But if it's much more, we need to address that. So if we have to go for a laser vision correction if the error is less than 1 diopter, but we have to exclude all the other contraindications for this. And if it's more than 1 diopter, go with an IOL exchange or a piggy bag IOL. So IOL exchange is challenging. And use a Virgin's formula while calculating the IOL exchange. And then piggy bag IOL, yes, this is an optimal choice whenever we don't know the IOL power that has been implanted or in hyperopic surprise. And this is a norm used to calculate the piggy bag IOL. And this is the norm used for calculating the IOL exchange power, which needs to be implanted. And suppose if it's not a spherical error but a cylindrical error, less than 1 diopters, we need to go with LRAs, otherwise limbal relaxing incisions. Or if it's an IOL misplacement, a toric IOL not placed properly, we have to go for rotation. So then these are some of the online calculators for this. And this is the algorithm which we follow for treating the errors. And finally, never forget who your patient is. So never try to treat patients by surgical modalities in patients who are expecting perfect results. And then thorough clinical examination is mandatory. And then according to the algorithm, we need to address the patient. And timing, it's always better that we plan multifocal IOLs or EDOF IOLs within a span of 2 weeks. Both eyes need to be operated within 2 weeks. And then we have to wait for 1 month for any procedure to perform, but IOL rotation can be taken up within 7 days also. Otherwise, IOL exchange can be planned within 4 months. And future, we have light adjustable lenses, and which can, with the help of UV light, we can almost adjust up to 2 diopters of a lens, 2 diopters of spherical error, and even perfect lens, which is coming up, which would be coming up in future. We would be able to address the error of the IOL up to 10 diopters with femtosecond laser. So to conclude, so we need to optimize the ocular surface, integrate the latest generation formulas, and use optical biometry, which is gold standard. And residual refractive errors should be evaluated clinically thoroughly, and never